I'm Diane Scherer, and I'm the Development Director of the diaTribe Foundation. Thank you so much for joining us today. So one of the biggest advancements of the past decade for people living with diabetes has been continuous glucose monitoring, CGM. Perhaps most importantly, this has given people with diabetes the information necessary to monitor their daily time in range. So that's the percentage of each day a person spends with their glucose between 70 to 180. This metric directly relates to the number of hours each day that a person living with diabetes feels their best and is least burdened by the disease. CGM has also revolutionized the way people manage insulin therapy, allowing for the development of hybrid closed-loop systems and bringing us closer to a true artificial pancreas. Biotechnology companies are tirelessly pursuing advances in CGM and insulin delivery technology, and today we are bringing together leaders from 3 incredible device manufacturers, along with a highly regarded clinician, to each provide their expertise about how these advancements can improve the lives of people with diabetes now and what we can look forward to in the future. So before we get started, I want to express huge gratitude to our sponsors who have made this event possible and all of diaTribe's work possible. Thank you to our gold sponsor, Abbott, which does so much to improve the lives of people with diabetes and to make CGM widely available. Also our gold sponsor, AstraZeneca, whose advancements in therapies are significantly reducing the risks of diabetes complications. Thank you so much to our dedicated silver sponsors, Bigfoot Biomedical, Dexcom, Genentech, Lilly Diabetes, and Vertex. diaTribe appreciates each of you. So CGM and time and range affect the decisions I make every hour of my life. I have been living with diabetes for 37 years, and I've been using CGM for past 12 of them. I did the calculation. It's been about 105,000 hours and over 1 million glucose data points that CGM has provided me so I can live my best life. That includes being an active mom of 3 young children and completing 2 half marathons. CGM and time and range enables me to have fewer paralyzing fears. I really try to show up each day with the tools I need for success. And I don't have to wait for that 3-month A1C to know if I'm on the right track. So over these past 12 years, I have seen immense advancements in CGM. It's empowered me to be the pilot of my own diabetes management. The knowledge CGM provides can facilitate more accurate insulin dosing, giving us all greater peace of mind as we utilize what is, in all honesty, a very dangerous drug that we rely upon. I still have my difficult days, but I am very grateful for the technologies available to me. And hopefully these can be made accessible to all the people with diabetes who can benefit from them. So before we dive in, let me give you a rundown of the event. After I ask our panelists the questions that we have, you all get your turn. We'll be pulling questions from the audience from the Q&A tab you see on the right-hand side of your screen. Please add your questions there. We'll get through as many as we can. There will also be some poll questions going up in the tab next to Q&A. Thank you in advance for answering them. They really do help us understand your experience and create better events for you in our audience. After the panel is complete, I really hope you'll stay online for some community networking. It's really so nice to chat with one another as a diabetes community. So it's now my honor to introduce our 4 amazing panelists. First, we have Laura Brandner, who is the Director of Real-World Evidence Programs at Abbott. Laura has spent over 15 years with Abbott, 10 of those in the diabetes division. Prior to her current role, she focused on the development of Abbott Diabetes products and digital platforms, including the Freestyle Libre Link app and the LibreView data management system. Now, Laura and her team work to turn these real-world data from millions of people using Freestyle Libre into insights that drive change and access. So hi, Laura. Next, we have Dr. Jim Malone, the Chief Medical Officer at Bigfoot Biomedical. Dr. Malone is a diabetes specialist and has been with Bigfoot since 2020 after retiring from Eli Lilly and Company. At Eli Lilly, he spent 21 years working to transform insulin analogs, GLP-1s, and insulin delivery devices. Dr. Malone also spent over a decade as a diabetes care specialist in Indianapolis. Dr. Malone is very active with JDRF. He is part of their cycling team and is immediate past president of their Indiana and Kentucky Board of Directors. Welcome, Dr. Malone. Hi.
Thank you, Diane.
Next, we have Dr. David Price, Dexcom's Vice President of Medical Affairs. Dr. Price has led the strategy and design of clinical trials, managed publication strategies, and provided medical input into Dexcom's product development. He has worked to really help make Dexcom products the best they can be. Dr. Price was key in advancing CGM for blood glucose monitoring, and he played a leading role in the Diamond and Mobile studies, which established the value of CGM for people on insulin. Dr. Price, hi. Thank you for being here.
Hello.
And last and certainly not least, we have Dr. Ananta Addala, a pediatric endocrinologist and physician scientist at Stanford University. Her research and clinical work are grounded in the social determinants of health. Dr. Adala aims to build an evidence-based approach to addressing type 1 diabetes disparities in youth, specifically focusing on youth from low socioeconomic and various racial and ethnic minority groups. Dr. Adala, welcome.
Thank you so much for having
me. Thank you all. All right, so let's get started with the questions. So let's frame it a little bit by talking about time and range, just going over a few basics for those in our audience who might be a little bit newer to time and range. So I'm going to give this to Ananta. Can you briefly describe what time and range is and how it is calculated? And how does it complement A1C as a measurement of glucose management from your clinician experience?
Yeah, happy to start off. And you actually did a fantastic job, not surprisingly, summarizing what TIR really is in your introduction. So what it is it essentially summarizes the percent that an individual spends in a specific glucose range. And typically we're thinking between 70 and 180 milligrams per deciliters. I should know that in millimole per mole, but I don't because I'm in America. So I apologize for my more international colleagues who might have a different set of parameters. And really, this is actually available on almost all CGM reports. It's directly available to the individual living with diabetes, but also their immediate sort of support network, which often includes families, providers. And it's important that we kind of, while we're talking about time and range, just touch for a moment on the fact that the target recommended, so the percent target time and range that's recommended is around 70% or around 16.8 hours per day that you spend between that 70 to 180 milligram per deciliter range. And these numbers were really set to minimize both short and long-term complications. And it's really, time and range is really starting to emerge, or maybe it's even established itself as the star in kind of understanding glycemia, because it really gives these real-time granular details on glycemic trends so that people can be adaptive, they can really flex, and they can also know what's coming. And probably, and again, as you alluded to in your introduction, is probably the most important is that it really allows individuals living with diabetes, their loved ones, their providers who care for them, to have some real-time actionable data at their fingertips so that it isn't a surprise, so that it's something that they can be proactive about.
Thank you. Thank you so much for opening up with that framing. That was very helpful. I know that two people can actually have the same A1C. For example, two people could have a 7, but they could have very different glycemic profiles and time and range data. So I'm going to turn this to David. Can you explain a little bit more about this in detail, and how does time and range act more useful than A1C alone? How can it improve lives?
Sure. Let's talk a little bit about A1C. So A1C has been the gold standard report card for assessing how someone is done in terms of their management. And it is a surrogate marker for the risk of complications of diabetes. And that was established way back in 1993 with the Diabetes Control and Complication Trial. It reflects the mean glucose. And I'm going to say it reflects it because in some individuals, it's a good reflection of mean glucose over the last 3 months. And in others, it is not. It may run higher or lower than the mean glucose. But again, it reflects the average glucose. It doesn't provide the time spent high, time spent low. And that's what the CGM metrics, the time in range, time above range, time below range do. And those metrics are really useful in managing someone. So if somebody has a good A1C, but a great deal of time low, they're not well controlled. And likewise, if someone has a good A1C, but they're running high a lot, there's opportunities to improve management. So the time and range metrics provide a lot more granularity and insights about changes that an individual needs to make in their diabetes management.
Thank you. Thank you so much, David. And I'll just chime in that for me personally, when I see that time and range number increase by 1%, that means 15 minutes of the day for people that want to think about this. And therefore, 4% means an hour of the day. And when you think about the overnight hours when one is sleeping and you get that data, that could be 7 hours of sleeping time. And that percentage really means a lot. So thank you so much, David. So Laura, can you explain a little bit about the role CGM plays in calculating time and range and some of the other data points that CGM enables, like the ambulatory glucose profile, and some people might not know what that is, and how they can benefit a person with living with diabetes?
Yeah, happy to. If you think about time in range being that percentage of a day that you're spending in that range, you need a lot of data to calculate that percentage. So technically you could calculate your time in range percentage if you're using a traditional blood glucose monitor, but you'd have to do a lot of finger pricking and over a long period of time. So what CGM sensors do is they continuously monitor and provide that stream of glucose data day and night, and it's calculating your time and range percentage easily. Time you're spending in, above, and below range. So that's what CGM allows, is that continuous stream of data that makes it really easy to calculate that time and range percentage. So you also talked about the ambulatory glucose profile, which is another type of report that becomes enabled with the use of CGM. And what that does is it visualizes each day's glucose traces collapse together so that you and your doctor can see trends more clearly, like what's happening around lunchtime, what's my risk of hypoglycemia in the morning, or when is my glucose the most stable. So the way I think about it, I'm not a clinician, but the way I think about it is that time and range and ambulatory glucose profile are really conversation starters for you and your healthcare professional to dig into the certain patterns and come up with an action plan.
I'd like to just chime in on one point along that when you mentioned that you could do with blood glucose measurements. And it's really not the same. Blood glucose, you could look at results in range. So it really depends on how often you test. You really don't get true time in range because you don't have the data. You don't have the true peaks, the true valleys. The periods you're not testing, you don't really get it. And when somebody's doing blood glucose testing, they may choose to test a lot when they are low, or they may choose to not test when they are low because they go by their symptoms. So just, I think that's more results in range than time in range with blood glucose measurements.
Thank you. Thank you for stating that. So Laura, you mentioned a little bit about what do you bring to your clinician? And so Ananta, I'm going to turn this next question to you. There's so many factors that affect time and range. It could be, 42 things. It could be stress, eating, exercise. We don't have time for it all on this event, but as a clinician, what would you say are your top 1 or 2 suggestions for people to improve their time and range?
Yeah, and I think before we sort of talk about the improvements or the changes that could come around, I think it's important that we remember when we're talking about diabetes management, we're really talking about just two components of a very complex person, not just their biology, but kind of who they are in all of their many ways. So we're typically looking at what's the glucose and how can I modulate the insulin, or potentially, add, ingested glucose in as well. And so I think that I don't think there's a secret sort of answer. Otherwise, I think we'd all be there, because I think it's a lot more work and effort than not. But I think the very first step is knowing your data and lockstep with that, right? Because we can't walk anywhere unless we take at least both legs moving. So lockstep with that is actually knowing that it's just a number. So I think anyone looking at the glucose data, whether it's the individual living with diabetes, the parent of somebody, a loved one, a partner, a provider, really, I think remembering that although we have numbers, to view it with some compassion and grace, because a lot of numbers and data, much like what was just said, can be a really good starting point, as long as there isn't judgment associated with it, as long as there isn't a self of sort of a sense of this is bad, or this I was better, or those type of. So I think I always lead. I do my best, and if any of my patients are listening, correct me if I'm wrong, but I think sort of starting with that place of a little bit of compassion and grace goes a long way, so that then you can start having an honest conversation with whoever the individual wants to engage as part of their care team. Ideally, it's also the provider, but it's what that support network is to say, okay, here's honestly where I am. And I think many individuals, once they have the data and step back and say, okay, this is a data point. It's not me, it's not who I am, but it's a place for me to start. And then they can say, all right, well, what can I honestly do? Where are those little incremental changes that I can make, that I can sustain, so that is a 1%, just like you were saying, that 1% time in range improvement. And really, honestly, by the time you get to 5% time in range improvement, you start seeing some serious improvement. So you're not asking for everyone to get to these colossal measures if they're not quite where either they or their provider or their loved one would like them to be. But I think really, so that's what I mean by there isn't a one or two thing, but I think knowing your data and then sort of having a little bit of kindness, but also a little bit of, all right, what am I willing to do?
Mm-hmm.
And then being a little honest, and then taking that first step, and then asking for help so that we can do it. And that looks different for everybody. And that's, I think, really where the individualization of care is really important, because everyone has different priorities. Again, I led by saying that this is just numbers. It's not the whole person. So that's sort of what I would say is the sort of key whenever I have this conversation. How are we going to move the needle? Ask them, you tell me first. You know better than I do, actually.
Thank you. Thank you. So to wrap up kind of your thoughts in this segment, I'm thinking of a few key words: empathy, individualism, one step at a time, honesty, honesty in terms of what does your day look like, the eating, the exercise habits. But I think you framed it very nicely. So I'm going to pivot a little bit about, in terms of how does all of this intersect with insulin dosing, and turn it over to an expert, Jim. So your work is largely focused on insulin dosing. How does CGM and the increase of the adoption of time and range assist in making some of these treatment decisions?
Yeah, thanks, Diane. So I really feel that integrating insulin dosing with CGM is a really good way to help improve a person's diabetes control. At Bigfoot, we've developed a smart pen cap system that is a device that's put on the end of a disposable insulin pen that's electronic, and it communicates with the Abbott Freestyle Libre 2 sensor, and it also communicates with the smartphone app. And it provides a digital solution for patients who are on multiple daily injections. So it's not a system for patients on pumps, but those that are taking a long-acting insulin and a rapid-acting insulin at mealtime. They now have technology that using a pen cap can display a recommended insulin dose that they take based on the prescriber's input. They can decide if it's a small, medium, or large meal, for instance, and adjust the dose. And they can also, the pen cap also displays correction doses. So if a person has a high blood glucose, that correction dose will be added to their mealtime dose. and get them back under control in a more efficient manner. So in summary, I think that CGM is a great tool to really help people on insulin, help adjust their doses, especially those on injections.
Thank you. And thank you for opening up this discussion with that smart insulin pens work for a lot of people. And so I'll turn it to David in terms of anything to add to this in your role, anything with insulin therapy, with CGM, and perhaps specifically automated insulin delivery, pumps, et cetera.
Sure. Thanks for asking. I would say that it is a useful tool for people, whether they're on meal insulin or not. So we did a study called the MOBILE study and looked at people with type 2 diabetes that were using basal insulin with or without other therapies, just not prandial, no short-acting insulin. And the time and range improvements, despite really minimal changes in insulin dosing, were profound. So people were able to modify their food choices, their activity, and maybe even be more adherent to their insulin because of their CGM data. So we saw a large reduction in time over 250 milligram per deciliter, and like a 3.8 hour increase in time in range in that particular population using CGM. With automated insulin delivery with insulin pumps, I mean, pumps were always a tremendous help to people who were using intensive insulin therapy, in that it was simpler to take an extra bolus than pulling out a syringe and vial or a pen to take boluses, and people could tweak down their basal rates of based on exercise, or if their glucose was changing. But it took a lot of work. And now with CGM, all that's automated. So in connection with the pumps via algorithms, the algorithm is able to make the adjustments and really unburden users. And all the studies that have compared the automated insulin delivery systems versus manual adjustments made by users, the automated insulin delivery systems win in terms of increasing time and range, decreasing hypoglycemia.
Thank you. And thank you both for answering. I know these are very detailed questions, and perhaps some audience members will have questions later, but to expand upon it. So Laura, I'll turn it to you. There's so much data that CGM produces, and I believe that Abbott recently released the results of a large-scale real-world data analysis for both type 1 and type 2 diabetics using CGM, and they reduced their A1C. So can you expand upon this and tell us what you learned?
Yeah, definitely CGM produces a lot of data. You know this personally, and Diane, with your 1 million data points over the last 12 years.
Yeah.
So a few weeks ago at ATTD, which is a European diabetes conference, we announced the result of a meta-analysis, which is like a combination analysis of 75 real-world observational studies. And like you said, showing the improvements in A1C for people with type 1 and type 2. So we have other real-world evidence published that confirms the use of Freestyle Libre system is associated with reductions in A1Cs for adults and children with either type 1 or type 2 sustained up to 24 months. Going back to something that David was saying, it's not, CGM doesn't just have to be for people who are on multiple daily insulin or people who are on pumps, but we find that people with type 2 diabetes who use insulin are often restricted from accessing continuous glucose monitoring. So through clinical trials and real world studies, we want to demonstrate the significant improvement of glycemic control for anybody with diabetes when they're using CGM. So I think back to what Ananta was saying was, CGM is really giving you more information, so that can give you better insights and then drive more informed decisions.
Thank you. And yeah, so not only the medical and the dosing decisions with those data points, there's also a lot of data coming at you. And I guess, Ananta, from your clinician experience, do parents, families, children do they discuss this with you in terms of how much data and how it makes them feel psychologically, good or negative?
Yeah, this is a conversation that sometimes they bring to me, and frankly, sometimes I bring to them, and say, well, we're going to need to talk about this, because the response to having those many data points in a day is really, it's actually quite variable. Some families, some individuals, they have a lot of comfort just knowing that they don't have to be extremely proactive or worried or wonder what their blood glucoses are. There's starting to be a lot of evidence that basically a lot of studies and where we did interviews or we did surveys, and really parents, especially, they're able to sleep better at night, partners worry less. I mean, I think there's a lot of overall benefits. And then sometimes when those devices aren't working the way that it's expected, because technology is technology, and occasionally there's sort of this heightened anxiety because they'd realized how much comfort they'd had from having the technology. But the thing is, while some people consistently or predominantly have a positive response, others, they'll tend to sort of essentially, again, come back to the fact that these numbers feel very objective. And so it feels like, really these numbers, we should perfect them. And I think in there, sometimes things get lost. And so as far as the psychological impact, take time in range, for example. I mentioned that about 70% is the target that we aim for, time in range. But sometimes there's an interest to get as close to 100% as possible, and to really, that somehow being closer to 100 is better than being at 70. And while trying to optimize glucoses to whatever you want is important, sometimes it happens at the expense of other equally important things in life, like relationships, or in the case of parents, parenting, in the case of children, being able to have that extra birthday outing, or, and so really, while data can be really powerful, and it can be really helpful, and it can be impactful, and in many ways guide what decisions people come with, it's really important that the sort of all of us work to make sure that we don't lose sight of the person as a whole, right? So you'll notice that I'll get pretty redundant pretty quickly, because I think forgetting the person in diabetes and in the numbers can really end up in the situation where the data feel overwhelming. Because the question is really, what are we doing with the data? It's really to improve the life of that entire individual. And again, kind of the numbers coming down to being that one thing. So sometimes I do tell people, sometimes I give homework where I say, okay, when you come back to the next clinic visit, I'd love it if I could see some text between you two that is not about your blood glucose. That is about something else. Maybe it's about pickup for soccer, or maybe it's about dance. I mean, I want to see something else. And so sometimes it's about disengaging and realizing that there's so many other beautiful things for us to cultivate, but CGM helps us actually think less ideally about numbers. And so that's sort of what I try to work towards clinically. That's sort of my philosophy. There's lots of philosophies out there, but that's how I tend to help balance, because it can be a lot of data, trend arrows, what do you do with them? And then sort of this graduated, and I think it's really important that as you're getting the CGM, that you get good, solid training around it. So you know what these numbers mean, and you're not surprised when you have a meal and it goes up. Yeah, that's normal. But let's see how high, let's see how far above target, let's see how long it stays there. So,
we've generated some data where we've looked at how often people look at their apps, and there are some people that look at their apps a lot. But when we looked at the outcomes, their time in range, people that, and it's probably because of the alerts and alarms, people know when they need to look at it. So people that looked at it less and limited amounts versus those that looked at it lots had very similar time in range, time low, and time high. So again, I think it has the ability to unburden users, although again, some people obsess. Certainly we see that.
Thank you both. That's a great point. And I think what I hear you saying, and I would not want to go back 12 years ago, pre-CGM. So I know I'm clear, and I believe probably the diabetes community is clear, that we're so grateful for this technology. There is absolutely no doubt. But to just be mindful about your whole person, get through the day, be mindful about how much it's affecting you. But there's no
and really
doubt.
Remembering that 70%, it's not an arbitrary number, really. It's kind of set because you get most of the benefits that you need to around there. So I mean, if you naturally tend to get a little bit above that, that's okay. But to sort of always set that unrealistic goal of 100%, really, it detracts from more important things that we should all be doing.
Jim, is there anything you wanted to chime in, or Laura, before we?
Well, yeah, I'll just say that there's one other parameter of CGM that we haven't talked about that I like in particular. It's called GMI, or Glucose Management Indicator. This is, again, a calculated value. It used to be called estimated A1C, but that was a little confusing because it's not like A1C that, as David said, averages blood sugars over 2 or 3 months. It just averages blood sugars over, say, a 2-week period, which is oftentimes when clinicians look at profiles. And when you look at the GMI and the time in range, I think that's a powerful tool that people with diabetes can use to make fine-tuning adjustments during their day, be it their activity level, their eating level, or their insulin dosing. It really gives them the information they need to make changes week to week, and not just every 3 months when they go in and see their clinician. So I think it's a real valuable tool and something that is important to educate people who are using CGM on how best to utilize the time in range and this new parameter called GMI.
And since we're doing CGM metrics 2.0, I'm sure others will also say, some of the measures that get at variability is also really helpful, because it will make your ability to understand what doses, where you need some insulin dose changes or some additional support, a little bit more clear. So because variability is essentially from time to time, day to day, in that hour, how much difference are you seeing in your blood glucose values? And so if you find that generally even if blood sugars are above target, but the variability is not so much, you can almost know, oh yeah, I should probably get some more insulin around that time. Whereas if blood sugars are above target, but the variability is really high, there might be days when you're actually having, at that hour, say at lunchtime, having a blood sugar below target, and then some days you're having it above. It's much more challenging to make informed dose change. So while we're doing a 2.0 talk, thank you, Jim, for taking us there. I think the variability is the one other thing that I think some of us probably get pretty excited about. Others probably more than me, but I'm still pretty excited.
Yeah, no, thank you guys for bringing up these definitions for people that do want a little bit more of an advanced understanding. Really appreciate it. And I realized, Jim, one question might be that we didn't really talk about the type of person that a smart pen might be appropriate for, just because it's a newer technology. Is there the type that are generally good for smart pens?
Yeah, good question, Diane. I think, as I mentioned before, for people that are on multiple daily injections, I think that's certainly the type of therapy that's amenable to using a smart pen. Bigfoot Unity, our product is cleared for people that are 12 years of age or older and are on a long-acting insulin and a rapid-acting insulin. I saw a question flash up from someone in the audience about do you need separate pen caps for the short-acting and the long-acting? And yes, I'll go ahead and answer that now. So there is a black pen cap for the long-acting insulin. Since long-acting insulin is typically given at bedtime, that the black cap is associated with the long-acting insulin, and the white pen cap for the mealtime insulin. And the other point is that every insulin pen, the disposable pens, have a little different geometry. So we have to develop a pen cap for each specific insulin. So if your doctor changes your insulin or your insurance company says, hey, we're changing formularies, then Bigfoot will send you the new insulin cap for that particular insulin. So we cover most of the major insulins on the market, and that provides flexibility for people that have to change your insulin for whatever reason.
Thank you. So I guess I'm going to pivot to a slightly separate subject, but if people have, again, different questions later on the technicalities, we can get to that. We're going to talk a little bit about access to the population. So understanding that, so Ananta, this is for you, actually. Understanding that CGM is a choice for some people, but also some are not able to access it or afford it. What do you think the disparities are, and how does this play out between blood glucose monitoring and CGM?
Yeah, I think over this is a topic that's near and dear to my heart, so I will try to be concise and to the point, because I think that over the last few years, especially, we really started understanding with greater and greater clarity how big the rift really is, and how diabetes technology is being used. And so there's a lot of studies, and some of them I've had the pleasure of being able to read and then be sobered by the findings, which is that individuals who are from low socioeconomic groups, those who have public insurance, individuals who are racial ethnic minorities, they have really limited access to diabetes technology. And coming back to how you frame this question, importantly, it's not due to their personal preference alone. Oftentimes, it's essentially a decision that's made for certain subgroups and certain sociodemographic groups who are living with diabetes, either because of insurance coverage or because of the sort of read that a diabetes care team might have. And so it's really quite clear that this diabetes technology, all these innovative, really fantastic diabetes technologies, they've preferentially been used in those of the highest socioeconomic groups, and they're really not kind of getting to everyone. And a lot of what I do on a research level is trying to understand this better, because if we can understand why this happens, and hopefully we can start working towards kind of reversing it. And this group, both the audience and the panelists, will know that really diabetes technology, it improves glycemic outcomes, quality of life. That's really why we're having this conversation. In fact, we can't even have this conversation about time and range being the superstar of glycemic outcomes without having access to CGM. So, I mean, what we're seeing is that there is really a differential access that's specifically driving poorer health outcomes. So we're finding some data actually that in youth, especially since I'm in pediatrics, that kids now are doing worse than our poor kids now are doing worse than they were a decade ago. And it really seems to be because they have a differential access to diabetes technology. So, I mean, I think that how do the disparities play out? They play out all over the place, and they play out in multiple ways. And it looks like lowering the threshold for people to have the choice to start on diabetes technology. Okay. It's a really important way to address some of the disparities we're seeing both in technology use, but also in some of the glycemic outcomes that come out of it.
Yeah, thank you. Thank you so much. And I know I'm so proud to work at diaTribe, because this is one of the things that diaTribe Foundation truly cares about. So I'll turn it over to David. David, do you have a response? What do you think companies can do? And perhaps it has something to do with pharmacy benefits as well in terms of Dexcom. You're on mute, David.
How many times a day do I do that?
It's okay.
We need to make technology more accessible. And we need to provide better coverage. We need better coverage policies, and we need to simplify the workload by clinicians and patients in order to get that. So in terms of the coverage policies, those are dependent on the clinical data and the standards of care. And there's been incredible amounts of data that's been generated over the last decade, and really well-designed and robust randomized controlled trials that have helped change standards of care and improve coverage policies. And in fact, for example, right now for basal insulin users, we are hopeful, based on like the mobile study, that there's going to be expanded coverage to that population. And by the way, many of those people who in the mobile study, the majority of patients were non-white patients. So it really had, the majority were racial or socioeconomically diverse, and the outcomes were the same independent of race, insurance type, education level, numeracy. So all people benefit from CGM. So again, it's trying to get it more accessible, trying to inch coverage policies forward. And then in terms of the pharmacy benefit, that just simplifies if it's covered, the access to it. So it's often a simple prescription, maybe a certificate of medical necessity, but a person goes in the drugstore and walks away with their device. So it really simplifies the processes for individuals in order to get the devices.
Thank you.
Yeah, I'll just add, David, that I think it's very frustrating for us in the diabetes community when our patients can't get access to CGM, a real breakthrough tool. You know, when it first came out, it was kind of provided for type 1s because they were on insulin treatment. And even early on, they had to be poorly controlled and needed extra help. And gradually that's improved. So now most type 1s can get access to CGM. But we're still far away from getting access to all our type 2 patients, even those on insulin, where all the professional societies say the standard of care is if you're on insulin with type 1 or type 2, you should have access to CGM. And unfortunately, insurance companies have been slow to reimburse on that important group. And even those that are on oral agents or diet alone can benefit from CGM because of the modification of the lifestyle. So that's frustrating to me and many of us in the diabetes community. Is access to CGM is still a barrier, and it's literally life-saving, and we should continue to work really hard to make it accessible to all.
Right. There are still some states and some Medicaid states in which CGM is not provided. And clinicians and patients have to jump through the hoops in order to get CGM. And again, it's really discouraging and really upsetting when I hear about these cases and the difficulty that the patients and clinicians have to go through in order to get CGM for people in need.
And I think it's
I'll say it's disgusting, actually, in 2022.
I like the passion. Laura, I wanted to see if Laura had anything to say, and then I heard Ananta.
Yeah, I was going to say, kind of echoing what everybody else is saying as well, but you know, CGM is giving you more visibility into what's going on with your glucose, no matter what type of diabetes you have. So when we look at the RCT data, randomized control trial data, we also supplement that with real world data. We've seen rapid improvement in time and range in just a few days of wearing a sensor. So people are getting like immediate visibility to something they weren't able to see before. And so that's information they can use to modify behavior. Or like Jim was saying, they might not have to modify their medication, but they're modifying behavior, food, sleep, and they're acting, you know, pretty quickly on having that new information. So yeah, to change policies and to change standards of care, it requires evidence and clinical data supporting the claims that CGM can be beneficial and valuable for people with diabetes, no matter what type.
Yeah, and I was just going to add some context of sort of how we may have kind of gotten here, so to speak. So I think it's really important while we're talking about disparities to, the way that we define race, ethnicity in America is essentially more or less consistent with the U.S. Census Tract, which doesn't have any biological basis, but it does have these sort of social kind of other milieus and including things like discrimination and the lived experience of individuals and all of these that are actually baked into race and ethnicity as a variable or as a way that we evaluate it. So it shouldn't be a huge surprise, right? And I don't think anyone in the panel is surprised either that, a CGM works just as well for one racial ethnic group than another. And it's actually the same for example, individuals who are publicly insured versus privately insured. But the problem sort of, again, kind of coming back to how did these policies get made? And then I'll stop, I promise. And how did we kind of end up here is really just that a lot of the early trials and clinical kind of to look to see does CGM work didn't consistently include lower SES individuals. And sometimes that's still the case. And so then the public payers who have a smaller pot of cash say, I want to make sure it works. And there's no reason it shouldn't, obviously. And so I think there's what it leaves, though, and I tell people all the time, is almost no matter what your field is, there's this opportunity for you to make sure that you're including diverse individuals, so that question isn't even a question we need to answer anymore, because there really biologically should be no reason why it doesn't work. Perhaps the system could be built a little differently, or maybe But yeah, so I mean, that's sort of the how we got here in these sort of very circuitous, kind of cumbersome processes, and why it's only for one group and not another. And I think it's all of us kind of saying, yeah, it works. Can we move on to the next thing, which is equitable coverage?
So yeah, so this is a really important and deep discussion, and a lot of stuff has to be figured out. But what I clearly see is you all are so passionate about making sure it's accessible. So thank you. So I'm going to turn the conversation to, what's the crystal ball? What are the future advancements? So, the past decade has seen so many advances. Some people would call it, kind of like a revolution. Dexcom and Abbott have new versions of CGMs. They've been approved in Europe and hopefully in the US soon. So we want to know a little bit more. So Laura, about Abbott CGM, can you explain a little bit more about the future?
Sure. So I can talk about our latest generation product called FreeStyle Libre 3. So like you mentioned, it's available in Europe, and it's a small sensor that is about the size of 2 stacked pennies. Even though in our national coin shortage, we keep using money as our benchmark here. But it's worn on the back of your arm. It's the world's smallest and thinnest glucose sensor. And really don't notice it when you're wearing it. It's sending you continuous real-time readings every minute to your smartphone. You don't have to break your finger. So we're really glad that it's available in multiple countries in Europe now and coming to the US soon. It's under review by the FDA, so stay tuned for that. One other thing I'll mention is we think about all the different pieces involved in the ecosystem of managing diabetes. Pumps, pens, data, sensors. Abbott's also partnering with different insulin delivery, digital coaching, and technology companies to bring integrated solutions to streamline the diabetes care. So in Europe also, we recently announced a partnership with Diab and Ipsomed to work on an automated insulin delivery system, which will connect with the FreeStyle Libre 3 sensor. So that was just announced a couple weeks ago.
Very great. It's very exciting stuff. Thank you. David, I'll turn it over to you to talk a little bit about Dexcom products in the future.
Ditto. I mean, we're like Abbott and others. We're continuously improving our products. G7's an amazing product, and a lot of the changes are there to delight our customers. So it should allow more customization of different features. It's going to have a thinner, smaller transmitter. And again, it's in review by the FDA, so I'm not going to get into any of the specifics, but look at it that it is going to be the next gen and an improved CGM. G6 has been amazing. G7 is going to be better.
Thank you. We're excited to hear more. So Jim, I'll give you the platform to talk about any Bigfoot advancements in the future.
Yeah, what I'm excited about, Diane, is applying insulin dosing algorithms to patients that take injections. So right now, our system takes doses that are recommended by the clinician, and it doesn't automatically modify those doses the way an AID system does. So with that advancement, which is going to require developing the algorithm, testing the algorithm, validating it, I think we can bring some of the advances of an AID system to people that are on daily injection therapy.
Thank you. So, I mean, I'll just say that all 3 of your companies, surely the engineers and the doctors and the whole team working to help people's lives is truly applauded, and we look forward to hearing more. So thank you. So Ananta, from your perspective, I don't know if anyone has asked you or told you what they think would be most helpful in the future in regards to CGM, insulin delivery, if it's more important for the duration, the size, the algorithm, all of the above. What are you hearing in the clinical setting?
Yeah, I mean, I think all of the above is probably a good answer. And I know that everyone is working hard on it. And really, I mean, the amount of innovation that's happened in diabetes technology. It's really pretty unparalleled in my opinion. I mean, the advancement, that I think that people are looking for, though. I think it might be who I talk to, but I think it's also was very clear in this group of panelists is really that getting that cutting edge technology out to everybody. So it's not just, benefiting a subgroup, and how we do that is sort of some of the things that I hear more. I hear families that perhaps haven't been recruited for studies before, or haven't been engaged in sort of research development and sort of the design of a product say, oh, I wish they'd put this in Spanish, or I wish that they'd phrase this a little bit differently so I knew what they were getting at. And so really, if we can ask some of these individuals who maybe haven't been in research before, haven't been in some of these development before, what it'll do is it'll essentially start kind of opening up and making these technologies not only sort of legible, either in language and multiple languages, but also sort of understandable, because it's words that people know, it's concepts people want to understand. And so I think that's sort of a lot of the murmurings of what I'd like to hear is essentially making sure that these technologies, as they innovate, are taking everyone with them.
Got it. Thank you. So I think we have definitely time for some questions from our viewers. And before I do that, I just wanted to know if anyone wanted to respond to Ananta, or I'll just go into the question from the viewers. All right. So great. This one's for Laura. Will Freestyle Libre 3 integrate with automated insulin delivery systems? Will we need to only wear it on the back of the arm?
Yeah, so the partnership that I was mentioning in Europe with Ypsomed and CamDiab is for an automated insulin delivery system. So that's something that's being proposed in Europe, and you can imagine that we would want to do similar things in the US, once the system is approved. And right now, yes, the sensor is approved for use on the back of the arm. So that's where you wear it, and it's much smaller. The Freestyle Libre 3 sensor is much smaller and thinner, and I've been fortunate enough to wear one or two in our internal trials, and it's really, really small and not noticeable for me.
Okay, thank you. Great. So for David, why do blood glucose meter readings sometimes differ a lot from CGM? And why is CGM different from A1C sometimes?
So in terms of difference between blood glucose meters and CGM, I mean, it's expected. The CGM is measuring glucose in interstitial fluid. Our algorithm is adjusting it to reflect a plasma glucose, a blood glucose, like a blood glucose meter. But at times of rapid rates of change, there may be a difference. Sometimes early on when the sensor is first deployed, there are differences. I look at it that the body's getting used to the sensor's getting used to the body. There may be some differences at the beginning of sensor life. But again, they're measuring from different matrices. The good news is when people manage based on CGM, their outcomes tend to be better than management based on blood glucose meters. So even though there's some differences, management based on CGM seems to yield good outcomes. Now, with all sensors, with all CGM systems, if your readings don't match your symptoms, if you feel low and your sensor's not showing it, or you think you're high and your sensor's not showing it, you should be doing a blood glucose test and basing the decision on their blood glucose test. In terms of why CGM is different from A1C, that's probably referring to the GMI, why it's different. And it could be that the GMI is only reflecting a shorter period of time. It may be 2 weeks, 10 days, 3 weeks, where A1C is looking over 3 months. It may be also that your A1C, like as I mentioned, is an imperfect reflection of mean glucose. So your A1C may be reading higher or lower than your mean glucose. Also, there's laboratory error in an A1C measurement. So there's a whole slew of reasons why there could be those differences.
Thank you. Thanks for shining light on that. So it looks like we're getting a lot of questions about CGM controlling hypoglycemia during exercise. I know for me, because I like to run and keep in shape, it is sometimes hard, but exercise is important. So Ananta, what can you explain to us?
Yeah, I think there's a couple of things to think about. I think one is that sometimes because there's a lot of fluctuations that can happen when you're exercising, there might just be a slight delay between the CGM reading and not. And as these new generations come out, that delay might lessen. But I think a lot of times I tell people there's because I have this conversation a lot. People think of it less as exercise and more as a lot of monkey bar time or running around the playground as a pediatrician. So, but the fundamental concept is still the same, which is just that essentially your blood glucose has another backdoor into your cells. So your blood sugar drops a little bit faster than you expect. So I tell people, if you can, if it's a planned activity, go ahead and make sure that you are decreasing the amount of insulin that's going in beforehand. Some of these automated insulin delivery systems, they have an exercise mode. They have some of these other settings that can essentially do that. They give you less insulin. If you're on a multiple daily dose injection, then you can either bolus less for the meal right before, or you can, if you know that it's a planned activity, you can, or it's game day or practice day, you can actually give a little bit less basal the night before than you normally would. And then, what I also tell people is, if you start there and then you always have some complex carbs to kind of tide you through. But I think what people, some of it is a little bit of trial and error, but it's around setting things like if you don't have an automated insulin delivery system, but have a pump, make sure you at least take that hour beforehand to set your basal rates a little bit lower, so that way there's enough time to actually go in. And what do I mean by a little bit lower? Sometimes as little as 20%, frankly, sometimes as much as 50 or 60%. The other is to know what the exercise that you're doing is. Is it a long run, which is going to have a slightly different impact on your glucose versus are you weightlifting? And so there's what I would suggest is there is a lot of nuances that go into exercise. And if you know what your typical exercise routine is, then that's actually a good place to touch base, either with your doc or with an educator, with a CDCES, or if you have access to anyone who's an expert in exercise physiology. Those are the kind of individuals that can help you fine tune it. But that's where CGM is actually really helpful, because you can say, hey, I not only do I feel low, but I also see my downtrending arrow. Why don't I go ahead and grab that complex carb a little bit earlier than I'd planned? So.
Thank you. Yeah, exercise can be hard to tune in, but again, knowing your body, it's important. And I'm going to turn this next question to Jim. Someone is asking if there is a negative impact when a person with type 2 changes the glucose target range to 60 to 160, again, instead of 70 to 180.
Yeah, so the target range really needs to be individualized, whether a person has type 1 or type 2 diabetes. The suggested target of 70, 180, I say, is the general target for most people. But in an elderly person with type 2 diabetes, you may set a higher target, maybe 100 to 200, or someone who is they could have type 2, but they're younger, they're very healthy, and want to have lower glucose. You can lower that target. I would make the point, though, that 70 is really a good lower target range. I know there's some people that feel lower the better, but when you get below 70, you're getting very close to the hypoglycemic range. And so I probably wouldn't lower that target for most people because sometimes they can have hypoglycemia unawareness, where they don't have the symptoms of hypoglycemia when their blood glucose is dropping. And then it can suddenly become symptomatic. So at the upper level, I think it's fine to adjust it. The lower level, I wouldn't vary it too much beyond 70.
Thank you so much. So a question from Rachel, and I'll go Laura, David, then Jim. Is there any effort to address the needs of our older population who might need larger buttons, larger words, larger font? Anything Laura, you want to chime in?
Yeah, accessibility is super important, as we're building a product that is used by lots of different types of people. It's very hard to design one product that works for everybody, but definitely accessibility is on our minds, specifically in our Freestyle Libre Link app and Freestyle Libre 2 app. We have a text-to-speech option, so you can have the glucose number read out to you. You don't have to read it on the screen. But yeah, this is something we're definitely working on.
And from a Dexcom standpoint, ditto. I mean, obviously that's a population that is of need. One thing that we have is a connection to MySiri. So we have actually quite a few people that use MySiri to know what their glucose is. And we have had, there's a paper published in low vision or blind patients that have been successful using CGM with the MySiri feature to get to become aware of their glucose data.
Yeah, and I would say there's 2 points in providing a technology to older adults. One is that we used to always think that smaller is better. We talked about the smaller sensors. That's great. But when you get things too small, it can make it more difficult to access, not necessarily the sensors, but the controllers for the sensors. So smaller isn't always better. You reach a point of diminishing returns. The other point is in older adults, they can be more challenged with technology. So technology has to be made as simple as possible without all the bells and whistles. And with that technology becomes a responsibility for education. So we have to be very patient, educate the person on how to use that technology, give them practice exercises to do to make sure they can use the technology properly. And then I think they can really take advantage of the technology, even if you are an older adult and aren't used to all these whiz bangs that young people take for granted. Can be a more challenge for the older person.
Thank you. Just going to go to the next question in the mindfulness of time, and it's for Jim. Will the Bigfoot Unity work with Dexcom G6? Does it work on an InPen? And will the app work with an iPhone at some point in the future?
Okay, several questions there. First is our current Bigfoot Unity has been developed and integrated with the Abbott Freestyle Libre 2. So we're not compatible with Dexcom G6. Sorry about that, David. That's the state of where we are. In the future, that certainly could change, and we're open to looking at other sensing technologies. So down the pike, that certainly is possible. The other thing is about InPen. InPen is a different smart insulin pen that is its own system. It doesn't integrate with the CGM. It's only for rapid acting insulin, and primarily used for people with type 1 diabetes that are taking rapid acting insulin and need a smart pen for that use. Currently, Bigfoot Unity is compatible with Apple smartphones, with iOS systems, smartphone 7 or iPhone 7 or above. We're compatible with. What we're not compatible with currently is the Android system. And we know roughly half or sometimes greater than half of the population is using Android. The reason for that is we're a small startup biotech, and we did all our development work with the Apple iPhone, and that's what we are cleared for by the FDA. We are now developing an Android version and hope to have that available in the near future.
Thank you. Thank you. I know that our viewers really like to know these technicalities, so I really appreciate all of your responses. So this next question, I actually think rounds out this. Ananta, do you want to explain a little bit about any research that indicates if maintaining targeted A1C and time and range contributes to a reduction of the long-term adverse impacts on the human body?
Yeah, I think this question is, I think the short, I can give you a short answer, which is it seems like that's the case. So the question of how much benefit can you get, again, kind of past that 70%, or if you're looking at an A1C 7%, that starts getting a little more challenging to say. But it is pretty clear, and there's some more emerging data that's looking specifically at time and range to say that time and range has the same clout that the A1C historically has had. That the longer time you spend in the target A1C or target range, the less likelihood you have for some of these both short-term complications, things like severe hypoglycemia, which we've been talking about, as well as unintended diabetic ketoacidosis episodes, but also some of those long-term complications that we're always having everyone who lives with diabetes get screened for, which we thank you for all the blood work. But so I think that the answer pretty unequivocally at this point, and I think has been the case for quite a few decades, is the more in target you are. But again, I will come back, especially because I think this crowd will appreciate that it's not clear how much sort of more improvement, please use those words very loosely, you get with a 6.5 versus a 6 versus a 7. I mean, I think when you get down to those level of granularity, it might be good to put your feet up for a little while instead and have some mental health happiness kind of stuff. So I mean, that's a long way to say, yeah, it matters. How much it matters, we've got some pretty hard numbers and sort of places where we can say, yeah, once you start going above these numbers, 70%, okay, like there's work to be done, and let's come up with a solution. But much below that, like I said, might be good to smile a little bit, and if you can do that while do your diabetes management while smiling, then all the better.
Yes, thank you. Smiling helps. Thank you so much. I'll turn this next question to Laura, and then of course Jim and David chime in on the topic of non-invasive CGM. Any thoughts on the horizon of that?
I think there's a lot of stuff on the horizon when it comes to diabetes management. But I think there's still a ways for the technology to go as far as accuracy and as far as like what you can do with that data. But yeah, I think there's a lot of technological things we don't even know yet.
Yeah, let me chime in on that one. I think it really depends on what the indications are. Is it for people with diabetes, or is it for people without diabetes? How's the data going to be presented? What are the claims they're going to make? So again, in order to manage diabetes, you have to be able to differentiate a 60 from a 90. You have to know if the glucose is really low, and the non-invasive glucose sensors have had difficulties in that really low glucose range. So TBD. I mean, there's a lot of companies that have tried. Hundreds of companies have tried over decades, and others are working on it right now. So time will tell.
Yeah, I'll just add that I'm old enough to remember all the excitement about the Gluco Watch. That was a non-invasive technology that was developed probably sooner than the technology could support it. But it basically used the sweat from the wrist to transpose a glucose value. And it got a lot of excitement, but the bottom line, it wasn't accurate enough, wasn't nearly accurate enough. So I think technology is definitely improving, and I think we will have non-invasive CGM in the future, but they have to be accurate. The current CGMs have such good accuracy that we need to have a non-invasive system that matches that accuracy in order to get the real benefits from CGM.
Great, thank you. So I will say that I really appreciate all the questions that came in from our viewers. I think it really means that you all are the pilot of your own diabetes, and you really care and you have really inquisitive questions. So thank you for being a part of this. We're going to go to our lightning round closing comments. So 30 seconds each. What are you most excited about, and what concerns you the most for the diabetes community? I'll start with Laura, then Jim, then David, and then Ananta.
Sure. So I think my concern drives my excitement, if that's a fair way to say it. So the concern is, we've talked about it in this panel, the limited access to CGM. So the best healthcare solution is one that helps the most people. And we know, and we've generated data from millions of people using CGM, using Freestyle Libre specifically, that CGM is a game changer. And we're excited to continue to develop this evidence, put out this data to show that giving people access to information and enables them to make better and smarter healthcare decisions. And we have to continue advocating to healthcare professionals, to governments, and to insurance companies to recognize those benefits for their constituents, for their patients. So concerned about access, excited about access opportunity.
Jim?
Yeah, similar to what Laura was saying, I see the excitement in that we're now really incorporating digital technology in diabetes treatment in a real way, starting with CGM and going beyond. I think the evolution of new sensors are going to help us. We obviously have a sensor for glucose. How about applying a sensor for heart rate, a sensor for emotional levels, stress, for instance. Other sensors can be incorporated in this connected system that can further refine our body's needs to better control glucose. So that's very, very exciting. I think my biggest concern, going back to what Laura said and what Ananta has said, is access to this technology. We can't build a Mercedes-Benz for everyone, because everyone can't afford a Mercedes-Benz. It has to be economical, and then we have to be sure that people have access to it from all socioeconomic areas, all insurance levels, to level the playing field so everyone can participate in the improvement of diabetes control that we're all aspiring to.
I think I'm going to start off with what excites me. And I think CGM is proving to have value across the spectrum of people with diabetes. So it's going to I think it's trying to have CGM move earlier and earlier into the type 2 diabetes cascade. So to move from people on insulin to people on potentially GLP-1 receptor agonists, people on oral agents, and maybe even earlier, moving into people with prediabetes. There's clearly anecdotes of people having a benefit from it. The concern I have is that as more people are using CGM, and as you move earlier in the cascade, these people are followed by primary care clinicians who are already overwhelmed with their workload. So it's really trying to have the providers that are taking care of people with diabetes being able to provide solutions for them so that they could quickly access the data and utilize the data to make better management decisions, or help patients make better management decisions.
And I think I'm up. And I think I'll start with what I'm excited about too, which is you heard the panelists say it too, but for me, as someone who's been interested in making sure that everyone has access to technology for a long time, I'm really excited by how many people are aware and interested in making sure that technology is available to everyone. So, and then I'm going to continue with excitement only and say that, I'm really hopeful actually that we can use this time of kind of our collective awakening to the state of things to shake things up a bit, shake up our norms, tweak. I don't need everyone to fundamentally change their perspectives, but at least try to come from a different vantage point to just think on how we can be more inclusive, like the question around, what about elder adults? And then all of the sort of other typical questions that I ask, to, just make sure that our work as a whole is more inclusive, that it's more equitable. Sometimes I talk to a lot of our sort of medical learners about this, and they get a little overwhelmed because it seems like, gosh, everywhere I look, there's only work to be done. But I sort of flip that and I say, gosh, everywhere I look, there's work to be done. So everyone join in. You don't need to stop what you're doing, but just kind of tweak a little bit. And then what that does is it increases access so that way really we can make sure that we no longer have a world where we're leaving individuals behind while we innovate.
Thank you. Wow, thank you all. I'm just really humbled by the work of each of you, your expertise. I'm humbled by the mission of diaTribe Foundation and bringing content like this to our viewers. And as the moderator, I'll just say I'm only excited. I'm excited for the future of the technology. And, you know, if my kids or grandkids need it one day, who knows, then I look forward to that. So I'll thank each of you so much for being here and everyone for joining in. So we'll be staying online for the next little bit, about 20 minutes to half an hour, to do some networking and get to know one each other. You should see something on the left-hand side of your screen. So thank you so much.
Thank you. Take care.
Thank you, Diane.
Thank you.
Thanks, everyone.